So for those of you standing in the back, I know it's intimidating, but there's plenty of seats up here, so feel free to come have a seat. So our next speaker, Dr. John Kaufman, really needs no introduction into the world of IR. He completed his radiology residency and vascular and interventional radiology fellowship at Boston University at University Hospital in the former Boston City Hospital. Following this, he joined the vascular radiology department at MGH, where he worked for about 10 years. He relocated to the Daughter Interventional Institute in Portland, Oregon. He currently holds the Frederick S. Daughter Endowed Chair of Interventional Radiology and is the director of the Daughter Interventional Institute. He's published extensively and probably best known to us as the trainees as the author of The Requisites. He's held many professional leadership roles, including being the past president of SIR and most recently the chair of the ABR SIR Primary Certificate Task Force. Through this, they successfully got the ABMS to endorse the specialty of IR as a primary specialty of medicine. Please join me in welcoming Dr. Kaufman to the RIP program to discuss the new IR residency and IRDR certificate. He's also my dad, so.
Yeah, don't report me. Actually, there's a very funny story. First of all, thank you for not saying all those other things you told me you were going to say. Claire spent a couple weeks with us when she was a medical student and scrubbed in on a case, and a very simple case, and we're trying to do something, and I said, well, let me show you how to do that, sweetheart. And afterwards, a nurse came up to me and said, Dr. Kaufman, you cannot talk to a medical student like that. I'm going to report you. I said, wait. It's okay. It's okay. So you never assume that people know everything you know. So thanks for having me here. And this is really probably the most exciting place for me to be in the meeting, to be honest, because I look out here and I see really where we're going, the future, and the reason why we've worked so hard to get to the point to be able to talk about what I'm going to be talking about next. So really appreciate your being here, your interest. What you may not realize is that whether or not you've committed to IR, just the fact that you are here, you are now all signed up for IR, and welcome to the best specialty there is. So this is, you're going to hear about this a lot. It's the 50th anniversary. This was actually the first angioplasty that was done on a human that really started this whole expansion of image-guided intervention done by Charles Daughter. And he really early on understood there was a key element here that made this very different than all of the rest of radiology. And you can interpret this many ways, but essentially what you've just heard from Dr. Beasley and what you're going to continue to hear is that it's not enough to understand the imaging. It's not enough to know how to use the catheters and guide wires. To do this, you have to be a doctor in the full sense of the word and take care of patients beyond just the imaging and the procedural part. And that's really what has driven all this. So standing in the back of the room is Gary Becker, who was the person who actually got this thing to happen, the VIR subspecialty certificate. This was the beginning of this whole process. Before this, there was not really any kind of certification. There are fellowships all over the place, and Dr. Becker was instrumental in formulating the identity of what this subspecialty was, I think with the idea that we were headed in a certain direction, and these are sort of the components of what that subspecialty certificate are. These are the competencies that sort of make us a specialty. So you have to sort of think, well, what's the big deal, subspecialty, specialty, and why should I even be thinking about it? It's just terminology, and how is that useful? A specialty in this country is defined as a unique combination of skill sets that cannot be acquired in any single sort of training pathway, and therefore you need to assemble a whole new training pathway in order to have these. It's different than a subspecialty in which you are an area of focus within an existing specialty. So you may have real great expertise in a particular area, but it's really still encompassed within. And what makes us stand as a specialty is this third circle, the patient care. There are a lot of people that do imaging, and a lot of people do procedures, and a lot of people do patient care, but we're really the only group that has full competency in all of these things. So that makes us a specialty. The ABR agreed that we should be a specialty. about 7 years ago before we started going forward. And again, Dr. Becker was a huge influence on that. And the whole of medicine has passed off on this. So when we talk about IR residency, the IR specialty, it's not something that came out of SIR alone, or it did, but it's not just something that's from SIR. Every specialty in medicine has looked at this and said, we agree, this is truly a specialty, and it is in the best interest of patients to move forward in this direction. So even if there's a little pushback within DR, actually the whole rest of the world has seen the wisdom of this. And we're complicated. You just heard about this. If you were to say, well, how do you break this up? It's estimated that it would take 7 different specialties coming together, working together to replace what one IR does. I mean, that's pretty impressive. So there's a lot here and a lot to do and a lot to learn. So why change training? As we have a subspecialty certificate, it's a fellowship. Why should we consider changing training, which is really what was behind the whole movement. Becoming a specialty was part of what allowed us to change the training. And it's because you've heard, this is a very complex specialty. This is not something that's easy to learn, and it's very different than it was 20 or 30 years ago, when it was really a branch, the interventional branch, diagnostic branch of radiology. If you think of the roots of this, daughter did the first angioplasty in '64, but angiography, sort of needle-directed infusion of carbon dioxide into the peritoneal cavity to do CO2 peritonography. There were lots of invasive diagnostic procedures being done, but those were all diagnostic procedures. The patient showed up with a predetermined question, you found an answer, and then a management was carried out and planned by someone else. IR is not that at all. You've heard, IR is now, you consult on the patient, you formulate what the questions are, you work up the patient, order your imaging studies, get the results, formulate the treatment plan, execute the treatment plan, and then follow the patient up. So it's a very different thing than it was in the past. There are multiple ways to do this. You've heard about this. You may be doing this in a part of a radiology practice, or you may be doing it freestanding. You may be doing it as part of a surgical practice. So lots of different ways to do this. You need a very broad skill set when you come out of training. And clearly, make no mistake about this, this is really being done so that patients who get image-guided therapy will get the best image-guided therapy there is. This is not about turf, and this is not about protecting your income. This is really about doing the best thing for patients. We're all doctors, and that's what we want to do, and we want to do the best we can. And this will allow people doing image-guided intervention in a broad way to do good care. It doesn't mean that other people who do image-guided intervention can't do it, but will do it well. We sort of talked about this, why a specialty and why is this important. Everyone's going to be doing image-guided intervention. There's not a specialty other than maybe, I don't know, dermatology. I'm trying to think of one that doesn't use some imaging somewhere and look at images somewhere. So people are using imaging everywhere, but you need experts in imaging to push it forward. People will use image guidance for procedures everywhere, and that's probably better for patients, that the more people utilize this in a skilled way, the better. But you need one core group that's going to drive this whole thing forward, develop the new procedures, make the connections that no one else makes, and utilize their imaging competence to sort of push the boundaries of what you can actually do with the imaging, rather than just sort of adapt what you're doing at one level and just keeping it at the same level. And so that's why you want to have IR, and that's why everyone agrees to this. So this is the evolution. This is where we've ended up. 1992 was the accreditation of fellowships, so a little bit backwards. The fellowships were accredited first, the specialty was recognized, and then the specialty exam. I sometimes get these dates off just a little bit, and Gary knows the exact dates, but I think we're pretty close. But right from the beginning, we were saying, you know, it isn't quite right. We got to do more. So 5 years after the first subspecialty exam, we had already come out with a new training suggested pathway called the clinical pathway. And that actually exists today, and it's actually, you know, it's a very interesting 14 years later, it's getting a lot of play. It's a rejuggling of the allowed electives and rotations in a diagnostic residency to get more clinical and IR training. It's called the clinical pathway, and it's been very worked out. This group has been instrumental. In 2005, the direct pathway, which allowed someone transferring in from another residency, from surgery, to use one of their surgical years to peel back the DR requirements. So actually shortest DR training requirements there is. And then 2009, our first IR, just a pure IR certificate was rejected by the AVMS. Personally, I think it may have been one of the best things that ever happened to us. It forced us to completely retool, revisit what we're doing, to rethink it, and we ended up with the IR-DR certificate, which will be awarded at the end of an IR residency, a much, much stronger, robust, viable program. And for you, the people in training, gives you many, many more options when you're done with this and how you practice. So what is this? You know, again, now it's with the ACGME, just so you kind of know where the pathway is. It's approved by the AVMS. That's the first hurdle that took about 7 years. Then the ACGME has to then decide to adopt it, which it did at the early this year, and then needed to formulate the program requirements, really from scratch. Dan Saragoussis in the audience was very instrumental in that writing group. Those program requirements are pretty much set at this point, going through some final sort of revision checking and cross-checking within the ACGME. And once voted upon by the Radiology Residency Review Committee, will then become open for public comment. So in about April, you'll be able to log on to the ACGME website and actually see the details and nuts and bolts of what this program is going to look like. But the ACGME has been instrumental. Many of these slides are from Jean LaBerge, who was the task force director and one of the ABR trustees. So again, this is why we're doing it. We want better care for patients and better training. You'll get more time to do this training. It's essentially a 3-2 configuration, and I'll explain how that 3-2 works. And this program writes into it the clinical exposure and clinical training, which is part of VIR training now, but it's not mandated and not emphasized. This heavily emphasizes the clinical component of training. And it actually will allow, in some instances, and you'll see how this is going to work out, some people to go directly from med school into an IR residency. That will result in competency in certification in both diagnostic and IR. But actually, right from the get-go, know they're in an IR pathway and IR training. When we retooled this, it became very clear, for many reasons, that maintaining core competency in diagnostic imaging was essential. And it wasn't just a political move in order to get sign-on of diagnostic radiology. If you think about what makes us different from a lot of other people, it's the expertise in the imaging. It's the ability to take complex, advanced imaging and use it to plan, use it to conduct a procedure, and use it to follow up. You're not dependent on other people to look at the CT and tell you, is that a liver abscess or liver tumor, right? And then make a treatment decision based on a report or a discussion. And the ability in the future to have several different imaging modalities going at the same time while you're doing a complex imaging. You may have ultrasound guidance fused with a CT image projected onto your angio table where you're doing live imaging, potentially MR fusion images and perfusion, live perfusion images as you're watching a conduct of a procedure and understanding whether or not you're actually treating the appropriate part of the tumor or not. All this having your DR competency is going to be essential. It also fortuitously allows much more flexibility in how the training is going to work out. So here's the sort of the basics of it. It's going to be a 3-2 after internship, so people will still have to do an internship, and probably a surgical internship is a good way to go, but it can be any internship. If you think you're headed to pediatrics, you might want to do a year of pediatrics. If you think you're going to be doing pediatric intervention. Then the first 3 years of this training are absolutely identical to a diagnostic radiology residency and will be conducted in a diagnostic radiology residency, and you'll be indistinguishable to the rest of the world and your co-residents from the diagnostic radiology residents for those 3 years. Why is that? Well, if you want to have the DR certificate, you need to have the core training, and that is the new model of training is that our 1, 2, and 3 years are followed by a core competency exam. And the IR residents will take the same DR exam as the DR residents. And that is what then justifies having a certificate that has 2 specialties on the same certificate rather than just one. Then for the last 2 years, the 5-6 years, we focused on IR training. So that's the ideal world. And the only outside rotation required in this is a month of ICU, and that's not to make you an ICU expert and not to be able to have you say, oh, I can manage an ICU patient, but to really give you the familiarity with the critically ill patients that we frequently run into, whether they're trauma patients or septic patients, and have an understanding of the management of these patients and how you can participate in that, but not to make it that you're managing an acute MI in the ICU for 5 days. So it's really to be part of your procedural care. Because of the requirements of training, there will be some added diagnostic months that kind of have to be accommodated during those IR years. To get the full DR certification, you have to complete a certain amount of mammo and nukes. And you may say, oh, mammo and nukes, why am I doing that? Wait a minute. I think one of the emerging, very interesting fields of intervention is breast intervention. There are people who are ablating breast tumors with cryo. There are people that are aspirating tumors with large needles. So you never know where your next area of intervention will be. And nukes is PET scanning, is fusion imaging, is things that you really want to actually be able to know. So don't look at that and think, geez, I can just turn my brain off for those months. What's going to happen? So this has been approved. This is happening. This is how training is going to be. It is going to move forward. Everyone in this room will be probably touched by this in one way or another. But is it going to happen overnight? It's at the ACGME now. What happens after the ACGME approves it is it suddenly, on one day, it's the VIR subspecialty certificate, and the next day it's the new residency. It's not that easy to do. There are 90-plus fellowships. We hope every single fellowship converts to being a residency. There are different formats, which I'll discuss. And the ACGME is just people like you and I, and they just can only do a certain amount of work in a certain amount of time. And so it's probably going to take a number of years for all these programs to get converted and accredited. They're new residencies, so they have to be accredited. So it's a good time not to be a program director, actually, so you should be thankful, because that's a lot of work. So it'll probably be a 5 to 7 year process of conversion of the current fellowships to residencies. So you will be looking at a mixed world, where your options may be training in a conventional fellowship or training through an IR residency. The output will be equivalent during this period. The ABR is not going to leave everyone stranded. There are not going to be 2 different certificates, 2 classes of people. Everyone will end up with the same certificate during the transition period, so you don't need to worry about that. But your options will actually not be as limited as you might think, because it's going to take a fair amount of time. So we're hoping that the program requirements will be finalized. You will actually have the opportunity to comment on them. The comment period through the ACGME website is open to everybody, and your comments are as important, as valid as anyone's comments. Every comment gets addressed. So Jean LaBerge is probably hating me and Dan when I say, go ahead and comment, because every single comment has to have a response. And it's okay to say this is a good thing. In fact, it's kind of nice if you get on there and you think, actually, this is really good to have that posted as well. Things may or may not change in response to the comments. So that's good in the sense that this won't get derailed. It's unlikely that somebody could come out of the woods from another interest group and derail this somehow during this period. But things could change. Comments could be posted that really have to be addressed. So we think the first applications will come in 2015, and 2022 is the end of the fellowship. So really a long transition period. And I'll show you why that actually works. So these are the people that have worked on the ACGME. There are many very prominent people here. We have Dan in the room with us. This is probably the most important piece of information for you to come out of this, other than that the transition period is going to be gradual and you'll have options. There are going to be several formats for how this will look. And this is, right from the beginning, this is what we wanted, and a precedent exists for this already, so it's not something we can give credit for. But there are essentially going to be 2 different ways you can go through this program. One will be called the integrated, and the other will be independent. Those names may actually change, but essentially they connote matching straight out of med school or coming into this after having done your DR. So very analogous to the current fellowship situation. So if someone starts and says, you know, I like IR, I'm just not exactly sure yet, I'm ready to commit, you can start in DR, and then at a later point, in the same way that fellows are now matching into fellowships, find your training. And I'll show you a model based on other specialties how I think this is going to shake out. And so you will not have missed the boat if you are already in DR at this point and this comes in and any door is closed. In fact, there are 3 other specialties that do this. So this is what an integrated program would look like. It would be a program that a medical student would apply to coming out of medical school, single institution. You would the internship can be anywhere, but then a single institution with essentially a 3-2 training pathway. There'll be some months back and forth, and during the first 3 years, absolutely identical to a DR resident, same call, all this, same rotations, ending up with the same examination. At the end of the 2 years of IR, the ABR is still working out sort of all the details of the examination, but an examination that's going to be a little tougher than just the DR exam. You're getting a certificate that gives you competency in 2 specialties. You're not going to get it without having to examine a little differently. What I can tell you is there will be a DR component to the exam, which could contain a lot of IR in it, the computer part, and there will be an oral exam. We are not going to go away from an oral exam for the initial certification for IR. That ability to communicate is too important to this specialty, and so we need to be able to assess that as well as competency. So it'll be actually a little more of an examination than just for straight DR. Independent programs will have a lot of flexibility. So residents have to complete 2 years of training, but there's a sort of modification to that. And you can only do this after 4 years of diagnostic. And we were very concerned about diagnostic looking at this and saying, if they only do 3 years with me and then bail and leave me high and dry for that 4th year, I can't make a schedule, I can't predict. So it's going to be very difficult unless you move or you have family circumstances to leave after 3 years and go into a 2-year IR program. But if you do enough IR rotations and do enough procedures during your residency, you can actually use that as credit towards the 2-year IR residency component. So in other words, if you come out of a 4-year DR program, you're at a DR residency, they don't have the IR residency, you want to do IR, you prefer not to train for 6 years, and there are many places that will potentially want you to really only come for them for a year, at least in the early part, and you do a sufficient amount of IR-related rotations during your 4 years and 500 procedures. Now, an image-guided procedure is an image-guided procedure. I mean, it'd be great if you could do 500 TIPS procedures, but no one's going to do that. But you'll do a lot of biopsies, a lot of drainages, a lot of access. This is all image guidance, and it's all translatable. Then you can get 1 year credit. So I'll explain to you that's actually the pre-existing model in other specialties. Vascular surgery is actually a 3-year residency. So if you were to go into vascular surgery and do general surgery somewhere and then go somewhere else to do vascular surgery, on paper it's actually 3 years. But there's the ability to get 1 year of credit if that person has done enough vascular surgery during their general surgery. And I don't think there's a single person doing a 3-year vascular surgery residency after doing 5 years of general surgery in this country. So it's not a boondoggle. And the goal is you will come out with a lot of IR experience. You'll just get some of it at your DR residency and then the rest of the IR, the independent residency. So this is how it looks for the integrated. Most people will come in through med school. However, at any point during these 3 years, if you're at an institution that has an IR residency, you can flip over because you're identical. It's just a matter of scheduling during these years is whether or not you have the ability to do that. So internally, transfers can happen very easily, and you can transfer out. Say you have the other issue in your head, which is very real. You start an IR residency, you want to just do DR. Can you get out of it? You can very easily move out because you've done the same training. So tremendous flexibility, a little bit harder once you get into these years. And here we talked about the qualified transfer. The independent will come in at potentially two places. If you do straight DR and say you make the decision, which I think is a probably very reasonable decision, and some people may want to do this, that maybe I'll use the fourth year, I'm going to do a body imaging mini fellowship, I really want to focus on that, or a MR fellowship, and then I'm willing to do, I'll do 2 years of IR after that, and I'll be able to really be doing both in my practice at a very high level. Then you would enter here at this point. If you do enough of the IR during your residency, you would enter at this point as well. So what does this mean? For example, we have 4 fellows per year. We have 6 residents in our residency per year. There's no way that our DR program director, who actually helped write these program requirements, would say, okay, I'm going to give you 4 people per year. We have people who want to do other stuff. So we're looking at a blended approach to this, where we'll have some people, maybe 1 person per year coming through the residency, and then people coming in later on from other institutions. Actually, that's very appealing, because people come to you from other institutions with different skill sets and they bring fresh ideas. It's also very good for institutions that either don't have a residency or are not going to have an IR residency, and they want to be able to attract good people and move them along to provide that output. And it's very good for some. We have some fantastic fellowships that will become residencies, like Miami Vascular, Jim Beninati's program, which is not really formally attached to a residency. This keeps them completely in the game and keeps any of you that think, gee, I'd like to go train at Miami, that's definitely an option. You're not now precluded from ever doing that. Most likely, in order for harmony, the DR and IR program directors are going to be working very closely together. We're calling this an associate program director. It's likely that you'll be, if you're in an integrated program, be doing some DR call during the PGY5. Is this bad? No, this is actually good. You need to be competent in DR. So doing some of this actually is very good. And what is an IR or IR-related rotation? Well, actually now things get interesting. You could potentially spend a month on vascular surgery, not to learn how to do the interventional procedures, but to see how they run a clinic, how they think about venous disease, on an oncology rotation, on a cardiology rotation. And all of this stuff is relevant to what you're going to do in IR, and those can potentially count as IR-related rotations. So you can't do all of them on that, but these are details that will eventually get worked out. So there are definitely concerns about this. Funding is always a huge concern. With the independent model, it actually makes it very similar to the way things are. How you integrate an IR-DR with a DR or an IR residency, these actually, we think, with the new programs will be very easy to do. We definitely want DR residents to still get a lot of IR training. We talked about this at lunch with some people. It's to everyone's interest that all image-guided interventions, as many as possible, done by people with radiology training. So simple thoras and paras and biopsies can be done by diagnostic radiologists with some basic IR training. That's a good thing. We don't want to see that go away. It will make it a little harder to sort of select residents for this, but that's actually something we can deal with. There's a lot going on. Just about every major radiology organization is sort of focused on this. The ABR has restructured itself around this. There are committees in all these major organizations. And just very quickly, how does it work for other people? So vascular surgery, 2006, their primary certificate. They have 2 different pathways. The red is the independent programs. The blue is the integrated programs. You can see the number of programs over time is growing very slowly, and they're just now hitting about 40% of their programs have the integrated pathway, and most of them have both at the same institution. So they do this blended approach. And what does it mean? There are more and more, though. The total number of trainees is going up. As you can see, the integrated trainees are increasing in number. These add every year. and the independents are staying about the same. They are actually adding independent programs. So a potential output could be the reverse of what we were worried about, which would be a big cut in the trainees. We may end up in the pipeline actually having more and more people actually trained and do this. So just to let you know, the program requirements are out there. You will get access to see what they look like. Your comments will be very important. If you're a member of SIR, there will be e-blast that you'll get with a link so you can get on there. Positive and negative comments are very important. And you will then sort of, starting in 2014, begin the process of the first accreditation. And I think that's, thank you, and I'm happy to answer any questions. So it's actually a very exciting time for this specialty. If you're going into this, you're coming in at probably the biggest change in specialty since that first angioplasty. I mean, this really has the potential to completely change how we practice, what we practice, the world's perception of us. And as I say, this is the best job in medicine, and it'll just get better with this. Thanks.
We do have a couple of questions.
Okay. Believe me, if I went over or did this wrong, I'm going to hear about this.
So first question, do we know the programs that will adopt? Do we know the programs that will first adopt the integrated pathway?
Yeah, so this is information. There's a task force within the SIR that's collecting this information. We already have programs that have come forward and self-identified that they want to be early adopters. That will become public. We just have to sort of probably get it on the website. I think it's a little premature to put that out there until the program requirements are out there and both program directors can look at it and actually make a decision. We can go forward. So we didn't want to actually put that out, but there are probably 10 or 15 programs that have self-identified as wanting to be on very early with this. You know, like any change, there are going to be a couple of groups doing this, those that will jump right into this, probably stumble a little bit, those that are going to wait a little bit, see how the first ones do it, and then learn from them, and those that are just wait to the very last minute and do it. I would say for the medical students in the group, this is a great question to ask whenever you go somewhere to interview. Just ask them what they're doing about this and when they think they will have it. I would not nix a program because they don't have it if it's a great program, because you see, there are a lot of different ways that you're going to be able to get into this. So go to the program you really want to go to. But it will definitely help the process if you're asking this question. Medical students don't realize they are probably the most powerful people in the hospital. Right? So if the medical students ask for things and everyone wants to make sure the medical students, they're listening, because that's really where the future is. That's where the next generation is. And so when you let people know what you're interested in, people actually do listen.
So kind of along that same line, we had a question that said, for students interested in IR, do you recommend they take 1 year off if the program does not start until 2015?
No. So what I wasn't able to get into, Gary Becker, who's the executive director of the ABR, has left the room, so now I can talk freely. And just for disclosure, I'll be becoming one of the IR trustees in July, so I do have to be very careful. The ABR is working very carefully to make sure that nobody is left behind. No matter how you train during this transition period, no matter where you're trained, if you do the requisite training, whatever certificate you have, you will eventually have the IR-DR certificate. So you don't need to worry, I need to wait and make sure I go to this place, otherwise I won't get that certificate. You'll get the certificate one way or another as long as you maintain maintenance of certification. One of the joys of being an adult in medicine is maintenance of certification, and so as long as you're maintaining that, the board will be able to convert your certificate for you. So you don't need to worry about it. By the same token, none of us are worried. There will not be 2 certificates. Ours will also be converted as well. So there really will only be 1 credential. That's a very important organizational issue, structural issue in medicine. So don't hold back. Just go to the best, get the best training you think you can get, the best place you can be or where you want to be, and eventually you'll have this. So don't worry about that.
So the next question is, will funding for the new residency programs come from DR residency programs? And if so, how will we deal with pushback from DR?
Yeah. So this is a totally local question. There's some institutions that have extra GME funding, and actually Dan Sirgus is an expert in this. We've approached CMS to sort of inquire about the ability of, since this is a residency, not a fellowship, residencies are what are supported. And then generally the answer is your institutions have all the money they're going to get. You need to deal with it locally. That may be one reason that your program will choose an independent only and only take people that have done enough IR during their residency to come for 1 year. There would be no change in the funding stream at this point. It would cost the department and the institution the same amount. If an integrated program, if you think about it, is actually a revenue neutral, if it's within the same department, and the majority of these will be within one department with one chair overseeing the two program directors, so dealing with the same funding. But all of that is local. Our institution, we pay for our fellows. We have no institutional support for our fellows. So our decision, if we start having, our decision will be if they come in through the integrated, they will be paid through radiology during the radiology years, and then we'll take over their support when they come to the IR part of the residency. But this is all going to be local, and it will get worked out. And I think there's enough interest in this that programs are going to want to make it work out.
A couple more. For those of us who have to do fellowships, will there be fewer fellowships available? Will they be phased out as
So, yeah, no, they will. It's going to take about 7 years, and we estimate sort of the last graduates in 2022, which is just sort of kind of mind-boggling, but it will come very quickly. So there will be a transition, but there will be a period in which you are looking at either a fellowship or an IR residency. So you will be out interviewing, and when you're interviewing hopefully all at the same time, you'll just need to be clear as to what you're interviewing for and what you match to and what your expectations are. So there will be a transition period. We're trying to work out all those details now. And gradually, the fellowships will shrink because they have to. The ABMS, when all the other specialties said, you're right, IR is a specialty and it needs this new training, was very clear, but you can't also be a subspecialty. You can't have two different training programs. That actually was our model was to go forward, that we would allow the fellowships to go until we knew the residency was really going to get situated and then phase it out. And the ABMS, I think, which is executing their fiduciary role to protect the patients and eliminate confusion, said you can't have both. You have to pick one or the other, and it was pretty clear which one was the right direction. So that's why the fellowships will go away. So there will be a period of time when the fellowships shrink, but it won't matter. Remember, you will get the same certificate at the end, particularly very likely at the end of this transition, you will take the same exam, depending on how you come from. But so we have the latitude to allow some flexibility during a transition period, but not indefinitely. So you will be protected. So again, best training where you want to train that you think you can get, and don't worry about it. You will not be left out of this process.
The next question is, do you feel that graduates from the independent IR training pathway will be at a disadvantage when competing with graduates from the integrated pathway?
No. It's the same certificate. Your certificate will be, from the American Board of Radiology, certified in interventional radiology and diagnostic radiology. It doesn't matter which of the pathways you get there, it's the same certificate. You have the identical credential, so I don't think there should be any disadvantage that way. What the question may be saying, well, is it better training to do 2 years in one place versus this mixture? I think time will tell how that'll work out and how that'll shake out. I think for our purposes, it's really the total amount of training that's really important, and if you do it in 2 places as opposed to one, whether or not that's better or worse, I think there are people that might argue it's better to get that kind of mixed experience as opposed to one place. And other people will say, no, it's much better to be in one. You spend 2 years in the same place, and by the end of 2 years, you just have all this deeper knowledge. So I don't know if it'll be an advantage or disadvantage. Certainly, as I think about an employer, being an employer, that would not be one of the questions I would be concerned about. It would be really much more, the other issues related to employability. You just need to have that certificate when you're done.
I think that's it for questions. So thank you very much for your time.
So what are we doing for dinner tonight? No. All right. Thank you very much.